Also, WFNS Foundation has a very important aid, very important assistance on the hand of the advisory board. There are 18 prominent persons that for one or another modality of contribution to the success and achievement of the goals of the federation, of the foundation, sorry, are included in this list. And also let me tell you that the role of second vice president that are also working in very close collaboration with foundation is for us very much appreciated, and hence the work of Professor Gandour, who is the second vice president for Africa. And just focusing in hydrocephalus, I think that first of all we have to say that one of the important tasks of the foundation is very easy to be understood if we look at this paper published in 2019, the current capacity and deficit in the provision of essential neurosurgical care. And just trying to summarize, let's say that we still need more than 23,000 neurosurgeons worldwide in order to meet and to have met and to meet the needs in lower and middle income countries. And along with that, the issue of hydrocephalus. Also, this interesting paper published in 2019 and published by people linked to the foundation and federation, as we can see here, Dr. Kipark among others, and basically just reviewing more than 80 papers in order to know exactly about epidemiology and incidence of hydrocephalus. You can see the source of the data as easily understood. The countries that are having the highest percentage and incidence of hydrocephalus are at the same time those who have less published regarding that topic. Just as summary, let's see how Africa is having the highest number of total estimated new cases per year, more than 180,000. Also, with 53,000, Central America and Latin America are of importance due to the estimated cases per year, and also some areas of Southeast Asian region with as well 53,000 cases are, let's say, the three geographical areas of target regarding hydrocephalus. And also, if we compare, according to this publication, where the cases are coming from in regard to the World Bank classification, we can see how lower and middle income countries are harboring more than 318,000 cases, and countries from the area considered of the classification consider high income countries, only 12,000 cases are estimated to harbor hydrocephalus. So I think these are very striking figures that you can also see graphically in this drawing, in which we can see the areas in red as having the largest number of hydrocephalus. And the conclusion of this paper is in compliance with some other publication and our humble experience, is that hydrocephalus, as we all know, is a major public health concern, estimating more than 380,000 new individuals with this pathology, being Africa, Latin America, and Southeast of Asia, the regions of highest incidence of hydrocephalus, and so the areas of main interest for foundation. And Also interesting to say that if a patient or a person is living in low or middle income countries, will have 20-fold probabilities to suffer hydrocephalus. The last part of the conclusion is that international and coordinated effort toward this surgical capacity building is needed, and this is the role, one of the role of WFNS Foundation. If we look at the strategy plan done years ago, we have three main strategic priorities: educational activities, the creation of WFNS training center, and also the provision of neurosurgical equipment and care in underprivileged areas. And these three pillars of the foundation are also focusing in pediatric hydrocephalus. This is how a foundation can help, first of all, from specific courses, training courses. I think that one of these very good example can be this webinar arranged and organized by Professor El-Ghandour and Professor Kuroda. There are also specific courses for scientific committees, and I have to mention Dr. Nelsie Sanon, because Nelsie Sanon, if you go to the WFNS webpage, you will see Professor Sanon here. She's working in Sao Paulo, and also you will see how this committee has some subcommittee that is called Hydrocephalus Task Force, that is led by Professor Consencio Di Rocco. And also talking about the specific actions, we can mention actions of the Pediatric Neurosurgical Committee that I will not mention anything about that because fortunately we have Professor Sanon here to speak about, and also the subcommittee regarding the hydrocephalus project by Professor Di Rocco and Professor Chooks as an example of what are they doing. One good example is the project supported by the foundation in Kyrgyzstan, in the Bishkek National Center of Maternity and Childhood Care. And this is the way in this particular center, it has not been the only one. By the way, and the methodology, they have been doing things. First of all, international neurosurgical staff with WFNS presence and direct participation of INI with the Stiftung für Kinder Foundation from Germany are directly involved in this project. So first step was the evaluation of the necessities, the needs in that particular center and that particular very large area. Second step consisted of several visits when needed, trying to ascertain until which extent local doctors and nurses would need, let's say, training and education on that particular purpose. And the final step has been the building of an operating room, including microscope, endoscope, and cranial neurosurgical instrument that were donated by the foundation. And I have to mention that foundation is buying those instruments in a very cheap price, thanks to the generosity of Esculap, Stores, SAIS, Sishan, and some other companies. And regarding training center, just in a couple of minutes, we have two categories of training center. One of them is the so-called full program training center. That is to say, young neurosurgeons are going to this center, are listed here to be trained, and after 5-year cycle, they are going back to the country of origin to contribute to the development of neurosurgery, or just to start, in some cases, start neurosurgery as real pioneers. Second category is postgraduate training center. There is a very important number of training center all along the 5 continents or 4 continents. Australia doesn't have anyone. And that way, young neurosurgeons can go to spend some time in any of these centers that are at the same time not only providing fellowship and education, but also providing food and accommodation and sometimes scholarship. This is a very successful project, and I have to mention that very recently the University of Sao Paulo with Professor Shannon has been falling into this category of postgraduate WFNS training center, and there are several centers with a specific action for training in pediatric neurosurgery. I have to mention 2 of them, very successful: the Center of Professor Tatajiba in Tübingen, Germany, and also the center led by Professor David Adelson in USA. So my last slide to remember this very prominent honorary president, just going back to 20 years ago and just thanking them in behalf of everybody linked to neurosurgery and foundation activities, because their visionary way of doing things made a reality the foundation. This is my last slide. I'd like to finish my talk, but before that, I'd like to thank again my very good friend and brother, Professor El-Ghandour, for the kind invitation, and also Professor Kuruda, and thank you very much, Professor Shannon, and thank you to everyone for listening to my presentation.
Thank you very much, Professor Miguel Arraez. Very interesting talk. And
thank you, Miguel. Yeah. I think it's a very good presentation, and it's very important to everyone to understand how big role which is played by the WFNS Foundation. I can witness that the WFNS Foundation, under the leadership of Professor Miguel Arraez, is doing a very great job in supplying equipment, donations, supplying microscopes, drills to many neurosurgical centers in the developing countries and in sub-Saharan Africa, and supporting projects and research and programs, training programs especially in the developing countries like sub-Saharan Africa. Thank you very much, Professor Miguel Arraez. Now it's time to introduce Professor Nelsie Zenon. She is the chairman of the Pediatric Neurosurgery Committee of the World Federation of Neurosurgical Societies, and she is going to highlight the efforts played by this important committee in the field of pediatric neurosurgery all over the world.
Thank you very much, Nasser. Are you seeing my screen now?
Yes, it's perfect.
Thank you. I'm working in São Paulo. Our chairman at the university is Professor Feres Haddad. Maybe we can receive you in a microanatomy courses soon after the pandemic times. Thanks, Professor Miguel Arraez, to introduce the Pediatric Neurosurgical Committee of the World Federation that I have the privilege to run like a chair. Our mission is motivating the neurosurgical community, particularly the young neurosurgeons, and try to create opportunity to training, to learn, and increase the improvement of pediatric neurosurgical care. And the values is neurosurgical for the benefit of children's families, regardless of race, gender, political parties, or religions. Our resource we don't have at the moment, but we can work on education with our voluntary work and the social participation with other societies. Our focus is spina bifida, hydrocephalus, and brain injury prevention. We can do this kind of work without help. And particularly, we have the liaison with ISPN. At the beginning, it was Graham Fignan, after Federico Di Rocco and Zulma Tovar. We try with ISPN and World Federation Pediatric Neurosurgical Committee avoid overlapping meetings and try to combine meetings to have together. And one of the last presential meeting we got the privilege to visit, it was Egypt, Cairo. And after the pandemic times, we need to change our way to thinking. And after a kind of paralysis, we need to keep it going. And the World Federation lead this group and give us courage and force and means to continue to work aloud. And Federico Di Rocco organized a hybrid meeting in Lyon about hydrocephalus with presential, but also online speakers. And also in Argentina with Professor Beatriz Mantesi about violence prevention in a combined meeting with the society. How the Pediatric Neurosurgical Committee can work? We can organizing and promoting scientific events by ourselves, by the Pediatric Committee, but we can give support, endorsement, like we are doing now with the very organized Professor Nasser webinar series. It's a privilege to be on board. And also with ISPN, the Clash of Titans, leading by Sandeep Chatterjee from India, education chair of the Education Committee. I have the privilege to be with him like a vice chair. And we decided to build a website with the young and seniors neurosurgeons. The website is already online. We have working in several ways. At the moment, we are trying to connect with other society, building our logo. And if you can find all the international societies' contact websites and emails, you can find in our website. We can offer to everyone webinar on demand. If you have a special need, you can just send an email and we will provide a webinar for you in a focused way after your need be manifest. And if you'd like to be ISPN members, is quite easy just to go in. And if you need support letters, just send me your CV and we can introduce you to the International Society of Pediatric Neurosurgery. And our take-home message is the Pediatric Committee is a voluntary work, passionate, and everyone are welcome. If you'd like to work on education and would like to have our support, just ask and we will be there for you. And the next meeting, maybe we can meet each other presentially in Bogota, World Federation 2022. And always thanks very much to Professor Schutz, and thanks again Professor Nasser El-Ghandour for this privilege to be on board with you again. Thank you very much.
Thank you very much, Professor Nelsie. It's very important to understand, and I think all of us appreciate the hard work you are doing with your team in promoting neurosurgery through this important committee, Pediatric Neurosurgery Committee of the World Federation of Neurosurgical Societies. And I understand that you are focusing on the countries and the continents at which there is real neurosurgical, pediatric neurosurgical problems like hydrocephalus and meningomyelocele. And we have a lot of discussions before about how these diseases are almost endemic in Africa. And we appreciate your support through programs and through educating pediatric neurosurgeons all over the world. Thank you very much, Nelson. I think you are the chairperson of this session, and still we have two speakers. I will be glad if you introduce both of them and then open discussion.
Okay, thank you very much, Nasser, for the kind words. Now we call Professor Mitsuhito Moshi from Japan. He is professor and chairman of Department of Neurosurgery in Nagoya University, Japan. And we'll talk about modern concept of CSF dynamics. Please welcome Professor Moshi.
Okay, do you hear me?
You can start if you are ready. Thank you.
Do you hear me?
Yes, very well. Thank you very much.
Okay, so now it's just, okay. So, hello everyone. My name is Mase from Japan. So, is it okay? Can you hear me? Is the slide okay?
Yes, it's perfect. Thank you.
Okay, it's okay. Today's it's great honor and also it's my great pleasure for me to present this great webinar. So today's my talk is about modern concept of CSF dynamics. So it has believed for a long time that it's classical theory the CSF is produced in corpus and ventricle and goes through the aqueduct, mesentery, and also going to the surface of the brain and absorbed in the arachnoid villi. However, it's not true. Maybe there's many evidences. It's completely different now concept we have. So in the past, more than 100 years ago, many experiments was performed and CSF formation rate as obtained. However, it's not most of all is not physiological and also is not accurate and reliable. And then most reliable method to measure the CSF production rate is ventricular standard perfusion method. However, even this method, so there's no consideration of absorption into the ventricular wall. So on all these the measurement methods based on the classical theory, just only that CSF is produced in the plexus. So, but nowadays there's another theory that most of the CSF is come from the capillary, but it's not only capillary. So I will explain them. But of course, now there are many evidences that the CSF is not come from only the corpus. Or maybe the hydrocephalus can't be controlled by only the cauterization of the corpuscles, and also if you cauterize all of the corpuscles, still CSF remain in ventricle and circle spaces, and also chemical composition of the CSF did not change, not so much compared to the before and after the cauterization of the corpuscle. So it is clear that CSF come from not only the corpuscles. And then nowadays we have many methods to directly show the movement of the CSF. And this is one of the methods of the time slip method by the Dr. Yamada in Tokai University. He showed us the movement of the water molecules is rapid motor molecules. It's just moving very fastly for during several seconds, and then turbulent flows, and also the partial movement of the Sylvian fissure, and also no movement of the CSF in the surface of the brain. So now CSF does not flow as we have believed just for 100 years. So, and I have a little bit different topics, this is the talk is from here is on about the water movement, it's not completely same to the CSF, but the movement of the turnover of the water molecule is well known. Already we have known that about 90% of water molecule were extracted from the artery to the brain tissue by only single pass. If you inject H2O to the brain artery, so after the one pass, most of the water molecule go into the brain tissue. This is this property is based on this property. Brain PET can be performed, and it means the absolute value of the CSF. So we performed the dynamic PET study to evaluate the movement of the water molecule dynamics. We put that kind of drawing like this, and then measure the radioactivity curve during 13 minutes. So after the injection, the steep increase in the brain tissues in the motor molecules here, and its activity, and decrease gradually in the brains. And surprisingly, in cerebral spaces, the end of the measurement about 30 minutes. So nearly 30 or 40% of radioactivity can be seen in CSF spaces compared to the whole brain. And it's very quick movement of the water from the brain to the CSF space. And also PPC is proper system here. So it's much larger activity compared to the lateral ventricle. This means water molecules in cerebral space and around the brainstem is not come from lateral ventricle, maybe directly from the brain surface or something like that. And our result is supported by the other researchers. This is an experiment using the mice and the knockout mice, acroporin 1 and acroporin 4. So this experiment is performed using the MRI, measuring the water molecule movement in the CSF space. So here is the activity change of the water molecule in the MRI in a wild type like this. And very similar movement distribution can be seen in the knockout mice of acroporin 1. However, in case in acroporin 4 knockout mice, it's completely different movement. So this means the water molecule in CSF space is not by acroporin 1, but acroporin 4. This means most of the molecules of CSF, water molecule in CSF come from capillary, But here, water is not equal to the CSF. It is very important. So now I'm just watching evaluating the movement of the water. And now we know the water movement is only passive, fast, free, and bi-directional. So which factor regulates the control of water movement and distribution? What is the mechanism of the existence of the CS in ventricle and cerebral spaces? So the answer is the most important factor is osmotic pressure. So many different osmoids in different CSF spaces, each area has a certain different molecules contents. And so water molecule move only passively. So content of CSS keep and control the fluid volume and distribution in ventricle and cerebral space, I think. So now CSF does not circulate, I think, and also the CSF formation rate is unknown. So, but we have to answer where the CSF come from and gone. Then this is I think the schema. So maybe there is no objection. All the fluids come from the blood by capillary or by corpuscles. But the problem is where to go out, wash out. So most of the waters and CSFs go out through the capillary. Also, recently it is shown that the corpuscle also absorb the fluids, some substance. But other route is lymphatic drainage system. It's very important. So now we know the two lymphatic drainage system. The one is a drainage route from the CSF space directly, and the other is a drainage route from the brain parenchyma. This is the drainage system of the interstitial fluid. Okay, so this is a schema of this interstitial fluid drainage system by the Professor Wera in England. So high molecular weight substances cannot absorb into the capillary. So that kind of waste is go along the arterial wall and wash out to the cervical lymph node. The other route is directly the substances come from the CSF to the directly to the nasal lymphatic system through the cribulary plate and also the nerve root Cs. So why this system should be exist? So high molecular substance or the waste and the metabolite cannot be absorbed totally by the capillary. So in that case, we have to wash out these large molecules through the lymphatic drainage system. So this is cervical hemorrhage picture. So 1 or 2 weeks later, the metabolite of the cervical clot has disappeared from the CSF. Where the clot is gone? Is absorbed in the brain, in the capillary, or the alveolar vein? It's not true. It's not. It can be believed. Most of the waste of the clot is drained by a lymphatic drainage system. Already nowadays, there are many evidences is founded. This is the monkey model that you can see. This is the brown network, is epidural lymphatic network system in monkey. This is a direct route from the CSF space to the spinal lymph node. And also there is another experiment by the Dr. Mueller in anatomy. So he injected the dye into the spinal subcutaneous space, and dye goes to goes through the nerve root and attack, go to the spinal lymph node also. And this is the same experiment using cadaver human ICG injection. So here you can see the ICG here, nerve root and also the lymph node. You can see those are same finding the distribution CSF using MRI in the human like this. So here is the the brachial plexus until plexus the CSF is go out from the CSF spaces. So now most recently there's another another route was found here. This is the lymphatic vessel exists just around sagittal cells in mice and also human. Nowadays the radiologists show that clearly this is the human parasagittal sinus lymphatic vessel like this. But it is unknown that how these substances go into the lymphatic vessel. It is here, this route is unknown, still controversial. So nowadays, the diagnosis, not circulation movement is like this. So all the fluids come from blood here, and some of them that go through the choroidal plexus, and most of the fluids go to the interstitial fluid and also go to the CSF space and absorb through the alcohol biliary also, but only in case of the high ICP, it's not working always. Mainly go into the tissue and also capillary and also the choroidal plexus, and the other is go to the lymphatic drainage system. Okay, so in summary, the CSF does not circulate as classical theory. CSF formation rate published before is wrong. The CSF in different area has different content. The turnover CSF content is important, and water molecule moves passively according to the distribution of the content of the and its osmolarity. And then, so I have to say another topic, mechanism of ventricular dilatation. So I thought that I told you that CSF does not circulate. So why does the obstructive hydrocephalus occurs? So I can answer this. I can answer. And I think the disturbance of pulsation, not flow, of CSF causes ventricular dilatation. So role of CSF pulsation movement is as follows. The CSF moves very quickly to reduce pressure difference and keep intracranial compress constant. So if free movement of the CSF is disturbed, pressure difference occurred and resulting in the ventricular dilatation. I will this mechanism using the schema. So we call this is the CSF pulsation disturbance theory. So this is the brain, and the blue is the CSF. So ventricular model with pulsated brain. So here's the brain pulsation. If the brain volume is increased by the pulsation, maybe the increase of the pressure in the ventricle is compensated by the movement of the CSF outside the ventricle. Here the blue arrow, and also there's another reaction force exists in the ventricular wall. But once that is obstructed, the brain pulsation, the increase of pressure cannot compensated to the CSF movement. All the forces go to the ventricle wall as a reaction force. So at the time, to reduce the reaction force, the ventricle area is increased, and then unit area is decreased and equal to the same of the outside force. So this is the mechanism of ventricular dilatation. So in the ventricle, CSF intraventricular CSF cannot be moved freely by the brain pulsation. No pressure compensation. So post ventricular wall in a unit area increases. Then ventricular dilated to reduce the force of the wall in the unit area until the same level of the force from the brain. In summary, fluid water should exist in ventricle and cerebral spaces. Mechanism of the ventricle dilatation is an ongoing subject to be solved, but may be due to excess water volume due to the osmotic abnormality and also disturbance of the CSF pulse movement. Thank you for your attention.
Thank you very much, Professor Moos. Very interesting concept on CSF dynamics and the importance of the lymphatic vessels and the pressure on CSF. The question we'll be discussing at the end. And now we call Professor Kazadi El-Ghandour. Professor is chairman of Department of Neurosurgery, University of Zimbabwe, former second vice president of the World Federation, second vice president of CANS, Continental Association of African Neurosurgical Society, and former president of ANSA. Professor El-Ghandour will talk about sample method of prevent infection on VP shunt insertion. Thank you very much for coming, and please feel free to share your slides and start your presentation.
Thank you very much. Can you hear me?
Yes, we are hearing you.
Okay, thank you very much. I'm going to share my slides. Okay, can you see my slides?
Not yet. Probably they are coming.
Okay, let me see. Okay, here we are. So share.
Yes, on the green button.
Okay, here we are.
Yes, yes.
Can you see that?
You can, yes, you can pull full screen will be better.
Let me try the full screen.
Yes.
Oh, sorry, where is it?
Usually is down. Here you have on the right side, down. Right side down, the left one.
Okay. Usually I get it. Okay, let me see. Here we are.
Just yes, move up and right, up a little bit and right now. Yes, you find. Perfect, Professor.
Thank you very much. No
Welcome.
problem. Thank you very much. Can you still hear me?
Yes, perfectly.
Okay.
Thank you.
Thank you very much. Thank you very much for the invitation, and congratulations for this excellent organization. And I admire your courage to organize all these seminars in order to educate our young neurosurgeons, from which we also learn as well. Okay. So I'm going to talk about prevention of shunt infection using really very simple method. As you know, we can classify the shunt infections. And when we talk about infection, we talk about wound infection, we can talk about CSF infection, we can talk about infected shunt system and abdominal complications. I'm not going to go through all of them, but we are going certainly to talk about wound infections and CSF infections. And according to the classification, classical classification, where do we talk about infection? And what we should remember is that the shunt infection, the organisms which are most of the time found on the shunt infection are Staphylococcus species, coagulase negative, and Staphylococcus aureus. Then there are other microorganisms also. We know that as well. Okay, so and theirs constitute about between 67 to 85%. Okay, and also another something which is very important is that the infection comes not from necessarily from the air, from the air into theater. It's actually the colonization of shunt by skin flora. Okay, and you know that the CSF shunt acts as a foreign body. It cannot defend itself from colonization from all those microorganisms. So the other factor we need to know is that usually most of the infections, they occur on the first month, about 70%. Now, if you combine between first month and then the second infection between 9 months, both put together, that's where you get maximum of infections. And it's very rare that you get infections later on. So having said that, it is well known that the majority of shunt infections occur secondary to colonization, as I said before, during the time of surgery. What does it mean? If we want to prevent, we need to look into our attitude during the operation. And I refer to the Department of Pediatric Neurosurgery at the Timon in Marseille. And they studied this and then confirmed that. And these have been confirmed also by other authors. Okay. We have, of course, quite a lot of questions when we get the shunt infections. Okay, where do they come from? What are the consequences, problems, and things like that? Here we are talking about the causes, and particularly we'll be talking about the prevention, so that we stay focused. The risk factors, I think we all know all of them. I'm not going to expand that because we don't have a lot of time. We need to focus and talk about that. There is a paper we wrote, and the title was Towards Zero Infection. It was published in Child Nervous System, and where we demonstrated that with minimal resources, we can actually prevent the shunt infection. Okay, just to show you where Zimbabwe is, and you can see that in red in Africa, and our medical school. And on this slide, you can see on the right side a valve, a shunt, we actually designed in Zimbabwe. Very simple shunt, and it works very well, and it's still working very well. But as I told you, the problem we get, beside other complications like obstruction of the shunt and so on, but we get infection. Now, we did a study, and this study was done in 3 countries. It was done in Zimbabwe, in Namibia, and in the Democratic Republic of Congo, and in Cameroon, to make sure that this technique really was valid and was validated by all those countries. And I'm showing the pictures of young neurosurgeons with whom we collaborated, and it's very interesting to see that this was done in multiple centers by these young neurosurgeons whom I supervised. Now, this is what we had. Globally, we know that the infection rate is between 3 to 20%. Can you still hear me? Hello?
Yes, it's perfect. Thank you. You can. Yes.
Thank you very much. The infection rate is between 3 to 20%. With our protocol, we managed to get the infection rate below 2%. I will explain a bit more about that. As you can imagine, hydrocephalus is the most frequent neurosurgical problem encountered in Africa, in the worldwide, and particularly in Africa. You see the picture there showing really one of the major cases. And this is not very rare to see this kind of patients coming to our hospitals. And we have, as I told you, and we know that these are the kind of things we can do. Endoscopic third ventriculoscopy, it's done also in several centers in Africa, but not in all patients we can do that. So VP shunt is still actually one of the major techniques we use. Has improved, as we know, the quality of life, but there are complications. Those complications, as everybody knows, there are infection among them, and there are also other complications. Today we are going to talk about infection. And there's been a lot of effort to try to reduce the infection, and the zero infection, but it's still far from dry. But we can get there. And in fact, nowadays, when you look in the literature, the current acceptable infection rate are less than 5 to 7%, which is still very high. If you can imagine the energy and the money which can be consumed by patients who have a shunt which is infected, 5 to 7%, it's a lot of money in developing countries. This was already mentioned that the majority of the infections occur actually within 2 weeks after the operation. And actually within a month, you have about 90% of the cases which are infected. So I repeat again that the infection, shunt infection, is actually a consequence of surgery. Okay. Now, we did this multi-center, of course, research. I'm not going into details. And the protocol, just to summarize, you see there is a long list. We actually did what other people are doing, but there's some things which we couldn't really do. Let's me summarize here. We do the shunt in the morning. That's a standard. The neonates and the infant are done before the older patients, okay? And we don't do the VP shunting from operation after the theater has been occupied by a case which was infected. We shave our patients. I know that this is controversial, that people do not shave, but it requires quite a bit of technology, not technology, I would say you need specialized nurses to shave patients in the ward. We prefer to shave them in theater, and we do it very well, okay? And patients are scrubbed with 10% povidone iodine, and but we don't put the plastic adhesive draping. That I can answer when people ask questions, because we believe that patients will be sweating under this plastic. And you know that the recolorization of the skin by bacteria comes actually from the glands, you know, from the bacteria coming from the skin. That's why we don't put them in plastic adhesive draping, although it is available. Now, the key point here we are doing, this is really where we differ from other protocols, is that we put intermittently during the operation, we apply povidone iodine 10%, about every 20 minutes. It means there is a paradigm shift. It means we are working in a wet environment. We don't dry. We want the skin to be always wet. And if for some reasons, technically, the instruments are a bit slippery because of this wet, we can dry the fingers, but the skin has to be wet. Every 20 minutes, we do that. Why? Because we know that bacteria, they start to recolonize the skin after 20 or 25 minutes, or sometimes even 30. That's why we do that. And of course, we give them prophylactic antibiotics like anybody else. That one doesn't change. With the protocol is more or less the same like others. Now, there is also another change, is that when we see the protocol, for instance, from Professor Schutz, they say in theater, there should be, now if you can watch the picture here on the left side, there should be only about 5 or 6 people, which is impossible in our environment, because we have students here, and actually there are others who are on this side, which you don't see. Usually the theater is always full, because these students, they need the signature that they've been seeing so many operations before they can sit for the exam. So the theater is always full. But beside the fact that the theater is full, we managed to have this low rate of infection. Those are details of the paper, but you are free to read really the papers, and you can see what was done. And that was the key factor, the simplest and the key factor which reduced the infection rate. Okay, so you see here, I'm just showing you the results, the way they occur, they happen, and they are seen in our paper. So our infection rate went down significantly low. And the 2 children who had a bit of infection, one had a leak which developed in 2 children, and a stitch abscess in 1 child, but without, without any shunt infection. Here you can compare with other studies which were done in the world. One does by Botolese, well-known, Rotin, Kessel, and of course, Professor Schuk's. You can see that we have managed to get actually to 1.9% infection rate, which is very low in a low-income country. I think this is really very important for us. So my conclusion is that we managed to show that it is possible to have a very low infection rate without actually spending a lot of money in shunts which are impregnated with antibiotics and with all the fancy things which can happen in theater. And this protocol has worked very well, sometimes in theaters where you thought there would be really 100% infection, but no infection actually occurred. So I hope I kept my time. Thank you very much.
Thank you very much, Professor Calango, not only for your lecture, very interesting, but also for the reality you are changing in your country and changing the mentality of the young neurosurgeons. I think you are doing a very good job, and congratulations again. If we have time, welcome, dear. We have some questions, Nasser. We can start some questions because of time.
Yes, we can have some questions. I know we are late, but we can take some questions, like 5 minutes maximum, because speakers of the next session would like to finish at exact time.
Okay, thank you.
So you have Nelsie, I think, questions on the Q&A, and 2 people or 2 colleagues raising their hands.
Okay, before start questions, Dr. Walter Mia Wadeta, I asked for about pediatric neurosurgery in your country because you don't have one. Please put your country name to try to keep in touch. And the questions are for Professor Meza. What is the cause of periventricular leak of CSF? Does this leak harm neural cells? Please, Professor. Are you with us?
I answered on the Q&A, you know.
Okay, can I do the second one? Maybe, I don't know if you answer already.
Okay.
The cervical lymphatic nodules, also you answer?
Yeah.
It's important to answer in public because the discussion is very beneficial for everybody. Would you answer the questions again, please?
Okay, so
if you can summarize your answer, we can help others. Thank you.
Okay. Okay. So what is the first question? I cannot see the question on the Q&A. So
okay.
Maybe, okay. I remind that why the CSF occur. That kind of question. So maybe in the ventricular wall and in ependyma, CS can be moved bidirectionally, bidirectional. So in situation of hydrocephalus state, maybe the direction is not into the ventricle, just to the brain tissue is much more. And then maybe based on the structure property in the frontal horn is a little bit weak compared to the other side. So maybe there is some CSF leakage shown in the periventricular high low density or the high intensity now MRI. But there's no evidence that kind of CSF can cause the neural damage or not. It's not evident. Is my answer.
Thank you very much. The second question is the same way. It's interesting. If you believe in lymphatic vessels on the CSF during meningitis, why we don't have cervical lymphatic nodules is because it's into the brain space, or we don't have technical equipment to try to detect these nodules, the lymphatic nodules on meningitis?
Okay, I think that maybe the lymphatic nodes, one of the lymphatic nodes is in cervical lymph node. But I think in for example, mice and jive or something like that, its main root is lymphatic cervical lymph node. But in human monkey, maybe the main root is maybe just the spinal labyrinth, much larger role of the lymphatic system. So, and also there's the possibility that the lymphatic node system is occluded before the lymph node, it's very difficult to wash out all the metabolite from the CSF directly, maybe obstruct the area, and then have the surface occur. So I don't know, because I cannot, I haven't seen the size of the lymph node in the meningitis. I'm sorry. Okay.
Thank you very much. Very interesting. Yes. Professor Miguel Arraes, please, did you have some answer for this colleague that are asking for how he can have a pediatric neurosurgeon in the country where they have 850 hydrocephalus children's case a year? How the World Federation Foundation can help them?
Well, there are several, as I mentioned before, there are several ways. One of them is, of course, by means of the appropriate training, that is to say, neurosurgeons concerned to hydrocephalus can visit the training center just to get the latest refinements regarding the neurosurgical care of that condition. Second possibility is on-site aid, on-site help. There has been several projects in Tanzania, in Kenya, according to which people from, let's say, Western countries with endoscope and even shunt surgical equipment have been going to Tanzania. And one of them, one very good friend from Spain, and with Dr. Lafuente and other colleagues have been visiting Tanzania for a while, doing procedure and just contributing to the education in that regard. We are, of course, fully open. Please, I ask to contact me and regarding the details and about details about what they want, and we will try to help them by all means. One of the issues is that the foundation is aware of the needs in some places, but in some other not. As a matter of fact, since long ago, we are trying to rebuild the so-called neurosurgical global map, trying to identify the areas in need, the need of neurosurgeons, and specific issues like hydrocephalus. Please email me and I will try to help you in as much as possible by means of different ways.
Thank you very much. The last question to Professor Calango. For your work, what was your main difficulty to implement the protocol and to change the mind on your environment?
Thank you very much for the question. In fact, everything started as a joke. I was operating one day and one of the instruments was missing, and I had the student around me. I couldn't actually shout the nurse. So while they were sterilizing the nurse, I was sort of explaining to students and making some jokes. And from time to time, I would say, okay, let me put some betadine, betadine, to remove bad spirits. So everybody laughed. So I left. From that day, all my juniors, each time they operate, they say, oh, let's remove bad spirits, according to Professor Calango. Let's remove bad spirits. So it became like a joke, which was going on. And then we realized that from that period on, the number of infections went actually down. That's when we ask ourselves questions. How come we don't have any more the kind of infection we were having before? that's how we did now all the statistic studies and so on and so forth, and find out that that was actually the key, which actually changed the whole thing. Because it came as a joke, I didn't have to sort of to impose it. It was basically accepted as something, you know, which came as a joke. You know, the usual thing we do, we've done it before, so we have our own professors, and our juniors, they are doing it for you know, to us. And it was actually a favorable change of the way, the concept, a paradigm shift.
Thank you very much. Thank you for all the speakers, and thanks for the audience to be with us. I call you, Nasser, just to run the session. Thank you.
Thank you. Thank you very much, Professor Nelson Zenon, for moderating this session. It was a great session, and all the talks were excellent talks, and discussion was wonderful. Now we move, before moving to the next session, let me welcome Professor Abhaya Kulkarni. He's a well-known pediatric neurosurgeon. He is from Canada, and I don't think he needs any introduction. He just joined our webinar now. Kulkarni, can you hear me?
I can hear you, yes, thank you.
Thank you for contribution to this webinar. Thanks to Professor Nelson Zenon. Now we move to our next session, and Professor Miguel Araiza, he will be the chairperson of the next session. Thank you very much.
Thank you very much, Professor El-Ghandour. I gather that next presentation is going to be done by Professor Kulkarni. Is that correct?
I think Kulkarni is the second speaker. Let me check the program, Miguel. The first speaker is from Japan, Professor Takuya Akai from Japan. He's going to speak about treatment of pediatric hydrocephalus.
Yes, my apologies, because I saw him in the initial panel with the speakers. So
Okay.
I apologize. And well, thank you for giving me the opportunity to chair this wonderful session, historical session with people from many places. And it's my pleasure just to ask Professor Takuya Akai from Japan to start his presentation on the treatment of pediatric hydrocephalus. Please, Professor Akai.
Yes, can you hear me?
Yes, perfectly well. Thank you.
Okay, thank you for your kind introduction. And hi, everyone. Hello from Japan. Today, I will talk about the general information about treatment of pediatric hydrocephalus. Today, I will talk about treatment strategy for pediatric hydrocephalus, and septostomy, and endoscopic third ventricular stomy, and chord plexus cauterization. First of all, I will show our strategy for pediatric hydrocephalus. For baby body weight less than 2 kilograms, we put subgarrial shunt. For baby weight over 2.5 kilograms, we put the BP shunt. For child aged over two years, we either put BP shunt or ETB. It depends on the condition. This is post-IVH hydrocephalus, and body weight, birth weight was just only 200 grams, and he had severe IVH, papille, right 2 and L4, and he developed hydrocephalus. For this baby, we did the subgarrial shunt first. It worked and for a while, but unfortunately, he got infection. It's miserable, and resulted in hemiventriculomegaly. For this patient, we used antibiotics, IV antibiotics, and did endoscopic surgery. I will show this video. And, we entered into the lateral ventricle on the contralateral side. This you can see is the foramen Monro and the septum. And we cauterized the septum and entered into the contralateral ventricle. and widens the hole, because this patient developed hemiventriculomegaly. We made communication between right side and left side ventricles and entered into the contralateral ventricle. Some hemogen deposit. And we come back to the left side and enter into the third ventricle. Now you can see the flow of third ventricle, mammillary bodies, and also aqueduct. Okay. Shunt infection is very complicated. So we mostly follow the hydrocephalus clinical research network protocol. This is a protocol, and the important thing is we put antibiotics before the incision and also use antibiotics post-operatively. We use antibiotics usually 2 to 3 days. And shunt infection is very complicated, so we have many proposals, many recommendations. Mostly in the former speaker mentioned, and we avoiding hair shaving in the ward and schedule BP shunt as first morning procedure. At the operation, and we do a limited shaving and keep door closed and limited stuff, and should be done by experienced surgeon, limited hardware in surgical technique. And procedure less than 30 minutes and double gloving, meticulous skin manipulation, and open abdominal first and close cranial first. That is very important. And we have to avoid post-operative CS freak. This is especially for child. Open sterile package at last moment, not place ligatures in the surface side. This is also important for babies. And perioperative antibiotic prophylaxis, antibiotics, we use antibiotics pregnated catheters. And post-operative period, we keep head position to avoid pressure to valve and around, and we have to avoid the CS freak. And second topic is septostomy. This is MMC baby, myomeningeal, and we put a shunt for this baby, but he developed an isolated lateral ventricle. So for this patient, we did a septostomy from the left side. I will show another video. We entered into the left lateral ventricle, and you can see the choroid plexus, and this is septum. And we open the septum by cauterization. And we entered on the contralateral side. You can see the shunt tube in the right lateral ventricle. And next topic is endoscopic third ventricular stomy. We are not aggressive for child aged before 2 years. We may have a controversy for this. This is a proposal, very famous ETB success score by Professor Kulkarni. He's the next speaker. And age is very important in his score. And the score is age, etiology, and previous shunt history. This is a big study about compared ETB and BP shunt. And there's over 5,000 infants less than 1 year old. In this study, and freedom from revision is not different between shunt and ETB, but failure risk of ETB was age before 90 days and prematurity and IBH. Next one is international infant study, Professor Kulkarni, and their study included age before 24 months and randomization or parental preference, and the entry was 158 patients, 115 ETB and 43 shunt. The point is age. This one, age, this crown, age before 6 months, shunt has a superior success. But age over 6 months, no difference. This is a case cloverleaf scar, the 1 year, 4 months. And this is before cranioplasty. And we did front orbital advancement and temporal cranioplasty. But this patient developed hydrocephalus like this. This is a head circumference, and we did cranioplasty, but the head circumference and continuously increased. So we did 3 weeks after ETB. At that time, ETB SS was 80. It's a good score. But 3 weeks later, and he developed the CSF leak from the wound. And also he had enlarged head circumferences. You can see this good window on the 3rd floor by this MR image. So we put the BP shunt and with programmable valve. And this is a change. This CT shows ventricular side change before ETB, and after ETB, it looks good. But he developed hydrocephalus again 3 weeks later, and we put the BP shunt. And next is CPC. We are not aggressive for CPC. We know CPC improved over CSF correction, but it's temporary, I think. And also, choroid plexus should have some role for brain homeostasis. This is baby body birth weight 1,500 grams, and he had a severe heart anomaly, so he had low saturation oxygen and malnutrition. And he also had myelomeningocele, and he had constipation and a small abdominal cavity. So we did CPC. This patient didn't have already lost septum, so it was not difficult. And we could cauterization on both sides. But so first we put the BP shunt, but it didn't work. So we did CPC, and it worked for a couple of months, but it didn't work a couple of months later. So we repeated CPC and we put BP shunt. So we think CPC work, but not permanent. And also choroid plexus has some role for CSF drainage, I think. This is our cadaverine injection study into the ventricle. The green fluorescent means a cadaverine deposit, and the red one, this is a CD35. It indicates the vessels. This is a Marge image. So this slide means CSF move into the choroid plexus. This is a choroid plexus. So CSF move into choroid plexus. So I think no shunt is best hydrocephalus treatment. Probably everyone thinks like that. But the shunt is a creditable treatment, and we still have to put shunt for some patients. Thank you for your attention.
Thank you very much, Professor Akai, for very nice presentation, very nice videos, and also for being inside the time frame. Now is a great honor for me to ask Professor Kulkarni to start his presentation about ETB with choroid plexus cauterization. I think this is a matter of debate nowadays, and we are very much looking forward to listening to your presentation. Professor
Thank you very
Kulkarni.
much. Yes, thank you very much. I really appreciate the opportunity to speak at this, and I thank you for the invitation. So I will talk about ETB with choroid plexus cauterization, and I want to begin by just saying I'm not going to present this as being a strong proponent or necessarily supporter of this procedure. I try to be very objective about this, so I think there's lots of room for discussion as to what this procedure actually is useful for, and I don't know the answer to that yet. So I'm still agnostic about this procedure. So just the early history of choroid plexus cauterization, I think most in this audience know that targeting the choroid plexus for treatment of hydrocephalus is over 100 years old. And so names like Lespinasse and Dandy tried to do this with sort of primitive endoscopic techniques. 100 years ago, they had a high morbidity, they had a high mortality. This continued on for several decades. And if you look in the 30s and 40s, there were a number of series written about choroid plexus cauterization or actual removal of choroid plexus using various techniques, including endoscopic techniques, but they were limited by the equipment that they had and their anesthetic techniques. And you could see here that the operative mortality was really tremendously high, well over 40%. So it was never a good treatment. And once shunts became available in the latter half of the last century, then of course, choroid plexus cauterization really fell away. There were certain centers that were doing it as sort of a niche procedure, but it was not a mainstream treatment for hydrocephalus anymore. And that changed somewhat about 20 years ago when Ben Worf started using the unique combination of ETV with choroid plexus cauterization from his work in Uganda. And so he'd published this, this was his first publication on this procedure in 2005. And what he was doing that was unique was that he was using a flexible endoscope. He was using a single coronal entry site and then accessing both lateral ventricles through one side, creating a septum pellucidotomy if the septum wasn't already fenestrated. And then he would attempt to cauterize all the choroid plexus in both lateral ventricles after having done the ETV in those patients. And this is just a video of what that looks like through a flexible scope. See this is the left lateral ventricle that we happen to be cauterizing here using a monopolar cautery, and you're just trying to blanch the pink choroid plexus to make it white, basically. And you just move along the choroid plexus of the body of the lateral ventricle into the atrium, and then finally into the temporal horn. And once it's completed, this is what you see, the blanched choroid plexus here, the white on the ipsilateral left side. And then I'll take you to the contralateral side. We've done a septum pellucidotomy, and we've already completed the choroid plexus cauterization on the right side, which you'll see shortly. And there it is. You see the blanched choroid plexus there. So that's what you're aiming for with this procedure. Now, what does it do? Why do we do this? Well, at least in the Uganda experience, what was shown statistically is that the choroid plexus cauterization improves the chances of ETV success in a wide range of etiologies. So certainly in their big etiologies like post-infectious hydrocephalus and myelomeningocele associated hydrocephalus, but also in congenital idiopathic hydrocephalus and congenital aqueductal stenosis, they showed very good results with CPC improving the outcome. The other thing they found was that CPC has a dose response effect, which I thought was very interesting and very important, which is to say that if you do a complete choroid plexus cauterization, your chances of ETV success are greater than if you only do a partial choroid plexus cauterization. And the chances of success with that are greater than if you do no choroid plexus cauterization. So that's kind of interesting in terms of maybe thinking about pathophysiologically how this procedure might work. And the Uganda experience also showed that in the percentage of patients that fail this procedure and then go on to have a subsequent shunt, there's no real difference in how that subsequent shunt functions in terms of its failure rate compared to those who had their shunt placed as the first treatment. So this was subjected to a randomized trial, which is very rare in pediatric neurosurgery, let alone hydrocephalus, let alone endoscopy. And this was a randomized trial that was done in Uganda, and this was comparing ETV-CPC to ventriculoperitoneal shunt in infants who had post-infectious hydrocephalus only. And what it showed, this was a secondary result here, that there really was not a significant difference in terms of the failure rate of these procedures. A shunt appeared to be a little bit better, but it was not statistically significant. These were 100 patients in total, roughly 50 randomized to each arm. But the primary outcome was this, because this was the real crux of the issue here. It wasn't so much about failure rate, it was what are the long-term cognitive outcomes in these children? And in particular, what is the effect of the large ventricle size on these cognitive outcomes? And what we found is that this is the Bayley scale of infant development. So the Bayley cognitive score was not significantly different between these two procedures. And in fact, when we reanalyzed this using various different things, when we adjusted for age and their baseline scores, when we did treatment as received versus intent to treat, when we found no difference with any of the other Bayley scores, and there was no difference in changes from baseline to 12 months either. So really, these two procedures appear to achieve a similar developmental and cognitive outcome, at least at 12 months in these infants. And I can tell you that these results are now sustainable up to 2 years. Those results have not yet been published. But what difference did we find? Well, not surprisingly, the ventricle size and CSF volume was a lot less in the shunted group versus the ETV group, which we all know to be true. We know that the ventricle size remains fairly large following endoscopy, as Professor Akai just showed in his talk just preceding this. But what we really were looking at was, what is the impact of that on brain volume? Just because you have large ventricles, does that necessarily mean your brain volume is compromised? And we found that that's not the case. So you can have large brain volumes and still, a large CSF volume, large ventricles, but still have good brain volume. And in fact, both of these procedures had similar degrees of brain volume and brain volume growth, regardless of ventricle size. And so here are 4 examples. So on the top are 2 patients who started off with abnormally low brain volumes, but then after treatment, they achieved normal brain volumes. In this patient, they achieved it with a shunt. In this patient, they achieved it with ETV-CPC. You can see the ventricles are still large here, but in fact, the brain volume is now back to normal, just as much as this patient is, even though the ventricle size is different. Contrary, you've got these patients here, these 2 patients who, despite being shunted here in the bottom left, and despite having ETV-CPC in the bottom right, their brain volumes did not recover. They remained with very small brain volumes. And why did we focus on brain volumes? Because this is one of the interesting results we found from this, is that those achieving normal brain volume had higher cognitive scores. And those who had substantial brain volume growth after treatment, they had greater improvements in their developmental scores. And there was really a positive correlation between brain volume and all the developmental scores, and this was not seen with CSF volume. So big ventricles, small ventricles did not matter to cognitive outcome, but larger brain did matter. And importantly, both these procedures were able to achieve similar degrees of brain volume. And I think that to me, that is the most important outcome from this particular study. And that brain volume really does appear to be the more important determinant of cognitive outcome, not CSF volume. And it raises the question as to whether we should be titrating our treatment to maximize brain growth rather than focusing on ventricle size. So that's a quick summary of what's been happening in Uganda. There's a lot more I could have talked about in that, but now I want to take you to North America, because this is, from what I see, this is not a procedure that has really taken much hold popularly in Europe, let's say, or many other parts of the world. But in North America, there's a growing interest in this. And so I'll present the experience that we have to date so far. There is a fair bit, but I'll highlight some of the bigger series. And one you have to talk about is Ben Worf's series from after his time in Uganda, when he came back to the US and Boston in particular. This is his most recent series, where he had 215 infants with ETV-CPC in that time period. You can see he shunted only 73 patients and ETV alone in only 19. So his practice was very highly skewed towards ETV CPC. The patient population was a standard mix of what we see here in North America with intraventricular hemorrhage of prematurity, myelomeningocele and aqueductal stenosis making up the majority of the population, and the vast majority of the patients were under 6 months. So a very, very typical North American infant hydrocephalus population. And what he found was that the predictors of failure of ETV-CPC was having a young age, which we've seen consistently in really all endoscopy literature and was mentioned by Professor Akai as well. Having a history of prior CSF diversion and having a lower Uganda ETV success score. So Professor Akai showed our usual standard ETV success score, but we also developed an ETV success score for Uganda, which includes the choroid plexus cauterization. And when he applied this to the Boston series, this score was also predictive of outcome, just like it was in Uganda. And these are the failure rates for his the procedures, comparing the shunted group here in red, which seems to do relatively poorly, to his ETV-CPC group, which does reasonably well. So about half of his patients did not need any further surgery. And then in a subset of the half that failed, he was able to redo the endoscopy and ultimately save them from a further shunt. So overall, using his protocol, about 70% of the infants that he treated were able to be treated without a shunt. And we can argue whether that in and of itself is a valuable outcome or not, because I think that's debatable. But if you think freedom from shunt is valuable, then 70% of his patients were free from shunt. Now, I'll present to you the data that we have from the Hydrocephalus Clinical Research Network. And this is a network that is comprised of 14 centers across North America, including us in Toronto here at Sick Kids. And we started to develop an interest in ETV-CPC, you can see here sort of in about 10 years ago. And in our network, which is, again, a large number of centers doing several hundred hydrocephalus cases every year, in 2006, we were only doing one of these per ETV-CPC, and then really not very much. And then there was a huge uptick here in 2013. And the reason for that is a number of us started getting interested in this procedure and whether it was useful or not. And we actually went to Uganda to study there, operate there, and learn from the surgeons there about how to do this procedure, because they had the greatest experience in the world with this. And then we brought that back to our centers in North America and started doing the procedure here. And so now we do, close to 100 cases of ETV-CPC a year across our network. And we did a number of ETV-CPC studies, but this one was our prospective study. And we did this prospective study as a prelude to a randomized trial, which I'll talk about at the end. But it was really to determine the feasibility of various eligibility and failure criteria that we were using, and to compare ETV-CPC outcomes to a historical shunt cohort. And we had 118 patients in this prospective series. The age here, you can see, again, skews very young, with the vast majority of infants under 6 months of age, which is what we would expect. And the etiology breakdown is very similar to what we saw with Dr. Worf's papers, where the big 3 etiologies are myelomeningocele, intraventricular hemorrhage of prematurity, and aqueductal stenosis. The ETV success score for these patients was predictably low, because this is, age is the biggest predictor in the ETV success score, and these were all very young infants. And so the vast majority of our patients had an ETV success score of under 50 or under, which means their predicted chance of success with ETV alone was less than 50%. And the majority, in fact, were in the 30 to 40% range. I mentioned that with this procedure, the goal of the procedure is to try to cauterize as much of the choroid plexus of both lateral ventricles as possible. And ideally, you want to get at least 90–95% of that choroid plexus that you can see in both lateral ventricles. And in this series, we only were able to do that in 3/4 of our patients. So 75% of the patients, we were able to do what we really needed to do. And I'm pointing this out just to be very open about this, because this represented our early experience. We were just learning to do this procedure. I'm speaking for myself personally, but also for the other surgeons in the network. And we certainly weren't as good at this as Ben Worf was, for example, who's done thousands of these. So we were still learning, and this is an indicator of the fact that we were still learning this procedure. Only 75% were we able to get this complete choroid plexus cauterization. These are the complications, and most are not that surprising. The one that I am a little bit worried about, when I saw this data, was the risk of seizures, which was about 5%. And these are infants, and in the couple of cases where I've seen this develop after this procedure, it has been temporary. It's often delayed their discharge from hospital, though, but they have had to be on phenobarb or some other type of anti-epileptic medication for at least several months. And I worry about this because so far, even though it's been temporary, my big concern with this is that we know from the quality of life studies that we've done in the hydrocephalus population, one of the strongest predictors of a poor quality of life is epilepsy and having seizures. So anytime I see seizures as a complication of a hydrocephalus procedure, it makes me worried. As I said, the vast majority of these have been temporary, but it does give me pause when I see seizure risk in this nature, in this ballpark. So this was our failure rate with this procedure. So it wasn't all that great, right? So just under 40% success rate. This doesn't include patients that we redid the procedure on. For some of those, that they improved as well. So the curve is a little bit better than that, but this is in terms of first-time failure. And when we compared this to a historical shunt cohort, you can see that our shunted patients did quite a bit better than the ETV-CPC patients. But, again, I have to caution and say that this relates to a couple of things, the type of patients that we selected for this procedure, and the fact that, again, we were inexperienced in doing this operation. This represents our early experience with this. And again, this is not randomized data. This is a historical comparison, but not randomized. So there's still a lot of issues that cloud our interpretation of these numbers and this curve. So in summary, what are the major questions, I think, for ETV-CPC in North America? So right now, what we don't know, are there certain etiologies of ETV-CPC, etiologies of hydrocephalus where ETV-CPC is not useful, where we should just go to shunt? And I think post-infectious hydrocephalus might be one of them. I don't know, but I think that's one of them. Because I should say that post-infectious hydrocephalus that we see in North America is very different than what they see in Uganda. Are there certain etiologies for which CPC adds very little to ETV? And I would argue that older infants with aqueductal stenosis, you don't need to do CPC. I didn't present the data, but thankfully Dr. Akai did. And this was, he presented the International Infant Hydrocephalus Study, which showed a very high success rate for ETV alone in infants with aqueductal stenosis who are over 6 months old. So that's a group where, why add the extra time and morbidity that comes with CPC for those patients? And a difficult question is, how low a success rate are parents willing to tolerate for the possibility of shunt freedom? So I'll have discussions with families, some of whom come to me and say, look, we know you do this procedure. Can you do this procedure on our baby? And I'll say, look, your child has, maybe a 30% chance of success with this. I wouldn't recommend it. Why not go to shunt? And some of them still insist that this is the procedure they want. And I don't know what the right answer is. And so I think that leads us with the biggest question is, how does this procedure compare to shunt? And who are the candidates that we should be considering for this procedure versus shunt? Because it's not a question just about ETV-CPC alone. It always has to be in discussion balanced with the risks and benefits of shunting. And so here is an area where I hope we're going to make some progress in the next few years, at least in North America, which is a randomized trial that the Hydrocephalus Clinical Research Network is running. This is a very large study supported by the National Institutes of Health, where we expect to randomize 176 patients into comparing ETV-CPC to ventricular peritoneal shunt. These are all infants under 24 months of age. We're excluding intraventricular hemorrhage and prematurity for reasons that I can discuss later. Our primary outcome, just like for the Uganda study, is cognitive outcome at 12 months. And we're going to follow these patients to 5 years. And one of the things that we're going to have with this study that we weren't able to do in Uganda, aside from having cognitive and quality of life outcomes, is that we're going to have very detailed MRI outcomes for these patients. We're going to look at diffusion tensor imaging and a number of other very detailed imaging features, and we're going to look at CSF biomarkers as well. So there's going to be a number of added features to this study that I think will make this a useful study, not just in terms of answering questions about ETB-CPC, I think, but answering questions about infant hydrocephalus in general. So we're very early days. So far we've enrolled only 9 patients. So we're getting there. So it's going to be several years still, but hopefully we'll have some very interesting results in the years to come. And I will stop with that. And once again, thank you very much. So Professor Isaac, you are muted, so we can't hear you.
That's right. Sorry, I didn't want to make any noise. So Professor Kulkarni, I was saying that you did a great presentation, very elegant, on a very, I think, very hot topic. Thank you for the presentation. And now it's my pleasure to ask Professor El-Ghandour, chairman and co-chairman, co-organizer of this educational course, to talk about ETB versus VP shunt in pediatric posterior fossa tumor, another important topic. Professor.
Thank you, Miguel, very much for this introduction. I think we are far behind our time schedule, and I have to be very fast. I also know that you have operation which starts at 4, and so I will cancel many of the slides, and I will just take less than 10 minutes. Topic for today is going to be about endoscopic third ventriculostomy versus ventriculoperitoneal shunt in treating pediatric posterior fossa tumors associated with obstructive hydrocephalus. Let us first start about Africa, because as you know, I'm working in Egypt and I'm the secretary of the Continental Association of African Neurosurgical Societies. And I have the pleasure to publish this article in the Neurosurgical Focus, speaking about challenges facing the promotion or the progression of neurosurgery in Africa. Most important is the lack of resources, shortage of facilities and basic equipment, problem in training, and the rapidly increasing population. What about the pediatric neurosurgery in Africa? We have very fast increase in population in Africa, much more than any other continent. Obviously, this is reflected in an increase in the pediatric age group. According to the World Bank, it estimates that 44% of African population is under 15 years of age. Of course, this leads to an increased incidence of pediatric neurosurgical problems. This is the Japan International Cooperation Agency, the headquarters in Osaka. This organization is doing a great job all over the world through many programs and projects. And one of these projects is the pediatric hospital affiliated to Cairo University, to which I'm affiliated. This pediatric hospital was constructed in 1983 as a donation from the JICA, thanks to government of Japan. And still, this is one of the biggest pediatric hospitals in Africa and the Middle East. And it's offering all pediatric neurosurgical services free without any expenses. All of us know that the classic management of advanced hydrocephalus due to posterior fossa tumors in children is temporary external ventricular drainage before definitive tumor resection. However, there is an important question. What are you going to do if you receive a patient with posterior fossa midline tumor associated with severe hydrocephalus, and you do not have access to perform urgent tumor excision? Facility unavailable and experience unavailable. So in this study, we are evaluating the role of endoscopic third ventriculostomy versus ventriculoperitoneal shunt in the management of these children. Surgical procedure is a classic endoscopic third ventriculostomy. I'm not going to speak about the the technical procedure. It's a well-known standard procedure. All of us know it. However, some people or some authors claim that the tumor usually displays the brainstem forward and obliterates the interpeduncular cistern, making endoscopic third ventriculostomy technically difficult or almost impossible. I didn't encounter any problem technically while doing endoscopic third ventriculostomy in these children. We have two groups, endoscopic third ventriculostomy group and ventriculoperitoneal shunt groups, and all of them came with advanced hydrocephalus. Just to be fast, we noticed that there is a statistically significant difference between the duration of the surgery and between the duration of the hospital stay. Concerning the morbidity and mortality, 38% of the patients with shunts had shunt obstruction and required revision, compared to 9.3% only in the ETV group, with a statistically significant difference between both groups. And this slide also shows the results of outcome between both procedures. Let me show some cases, pre-operative and post-operative, 3 days after the operation. As you can see that there is almost disappearance of the periventricular edema and decrease or reduction in the ventricular size and opening of the subarachnoid space. Another patient with medulloblastoma. And as you can see, post-operative MRI shows excellent improvement. Another patient and post-operative shows improvement in ventricular size. Another patient, this medulloblastoma extending inside the fourth ventricle, lateral recesses and to cerebellar peduncles, and post-operative is very good. This is sagittal MRI, and as you can notice, this is the fenestration created. It's very clear. This image is very interesting because, as you can see here, that there is fenestration between the third ventricle and the interpeduncular cistern, and pre-operative and post-operative images. This the flow-gated MRI, and you can see or you can notice that there is a flow signal void between the third ventricle and the cistern, and unidirectional flow, which signifies flow from the third ventricle to the interpeduncular cistern. During definitive surgery, the dura was lax, tapping was not necessary, cerebellar retraction was easy, good tumor exposure and dissection. And again, this shows the outcome post-operatively between both groups. This Kaplan-Meier curve, it was highly significant and showing that the group of endoscopic third ventriculostomy was much superior. Why to use endoscopic third ventriculostomy and why it is a good outcome? I think it's attributed that the hydrocephalus is acute and the floor of third ventricle is thin and could be fenestrated easy. Anatomy of the third ventricle is undisturbed. It's not like cases with myelodisciasis or aqueduct stenosis with minimal anatomical variants, and there is normal subarachnoid space with good cerebrospinal fluid absorption. The endoscopic third ventriculostomy is a minimal invasive visible procedure, whereas shunt is a blind procedure and it needs abdominal incision. There is no any sort of shunt dependency, of course, and there is no risk of seedling, and there is very low risk of upward herniation when compared to the shunting procedure. Many authors reported that there is high risk of upward herniation as detected by the brainstem auditory evoked potential. In many patients, it was a sort of subclinical upward herniation. Of course, the cost is less and the procedure is more fast. I recommend endoscopic third ventriculostomy for treatment of obstructive hydrocephalus, secondary to fossa tumors in children. We published our results in the Child Nervous System, and this publication had about 57 citations. And when I was honored to join the Neuroendoscopy Committee of the World Federation of Neurosurgical Societies in September 2017, I had a very important proposal saying that my aim is to make endoscopic third ventriculostomy a simple traditional procedure that can be performed by junior neurosurgeons the same like ventricular peritoneal shunt. What is the difference between both procedures? If we accept that junior neurosurgeons can perform shunting, we also should accept that they perform ventriculostomy. And I think one of the important targets of the neuroendoscopy committee is to train as much young neurosurgeons as possible so that they can perform endoscopic third ventriculostomy efficiently. And this is what I'm doing when we are organizing hands-on courses. We are targeting this point because it's very important to make it a traditional procedure, which is going to avoid a lot of complications and save a lot of money. Why ventriculostomy? It is safe, effective, easily, technically, because the anatomy is undisturbed, it's minimally invasive, and it's physiological. It's not like shunt dependency. We are offering scholarships to trainees from Africa and from developing countries concerning food and accommodation. We organized many hands-on workshops. This is the president of the WFNS, surrounded by faculty and trainees from Africa and many other countries. Another hands-on workshop in Egypt organized, and we invite all of you. Hopefully, if this pandemic becomes terminated, I'm organizing a very important Congress in October, 27 October to 30 October 2021, the third Men's Congress. All of you will be invited, but let us hope that this pandemic will be finished and we'll be able to hold this Congress in time. Otherwise, it's going to be postponed for next year. Thank you very much. When you come, maybe we celebrate the opening of the new Egyptian Museum. Thank you.
Thank you, Professor El-Ghandour. Thank you for just shortening the presentation in order to be on time in the session. I just am seeing a lot of congratulations to all the presenters. There is one question just to be addressed to Professor Kulkarni regarding about the cause of the growth of the brain or the size of the ventricle in ETB and CPC, the difference with BP shunt. What do you think is the real cause for that difference? This is the question of one of the panelists.
So what we found, I mean, we know that the difference in ventricle size is clear, but actually the difference in brain size is not. I think if that was the question about the brain growth differences, there really wasn't. At least in the small sample that we had, there was not a significant difference in brain growth between ETB, CPC, and shunt. I have to stress, this is a very unique population. These were the children in Uganda who had post-infectious hydrocephalus, and many of them had quite significant brain injury to begin with. So their brain volume started out very low. And I don't know how that translates to other types of hydrocephalus and kids we may see in other circumstances, but we hope that the randomized trial that we're doing now in North America will help us sort that out.
Thank you very much, Professor Kulkarni. And I have one question to Professor El-Ghandour, because this is a very important presentation. Of course, you are in favor of ETB for the treatment, preoperative or pre-resection procedure to treat hydrocephalus. Do you have any robot sketch of those cases that are not going to work? Because I gather some of the cases will not work. Do you have some profile for them?
You know, Miguel, the situation right now in many neurosurgical centers in Africa and other countries, they are putting shunt routinely pre-operative. That's because they have very long waiting list of patients. And at the same time, there is no facility to make tumor resection on an urgent basis, either due to lack of experienced personnel or lack of facility. As a result, they are put shunt, and shunt is life-saving. Of course, endoscopic third ventriculostomy will be much superior than shunting. And we expect after tumor resection that the cerebrospinal fluid pathways will be opened. And why to make the child to become shunt dependent if the CSF pathways are going to be opened. Ventriculostomy is going to be no longer needed, and it will be closed spontaneously post-operative. I think for all these low-setting, limited resource neurosurgical centers, if we teach all young neurosurgeons how to do endoscopic third ventriculostomy and to make it a traditional procedure, that will be the best solution for these patients, and it's life-saving. Post-operative, some patients, of course, according to literature, let us assume that 2/3 of these patients don't need any CSF diversion post-operative, and only 1/3 will continue to need this cerebrospinal diversion, either ventriculostomy or shunt.
Thank you. Thank you very much for your answer. I think we are a little behind schedule, and it's time to hand over to Professor El-Ghandour, the guiding of this talk and presentation of next moderator. Thank you very much. Congratulations for the great, these three great talk, and have a very nice weekend.
Thank you very much, Professor Miguel. You are always supporting our educational series. You are my true brother. I appreciate your support and your collaboration, your contribution all the time. Thank you very much. I know that you have emergency right now, and let us move to the third session in this educational symposium. And let me welcome Professor Lucas Rasulik. He is my brother, and he is president of the Serbian Neurosurgical Society, and he is the chairman of the Peripheral Nerves Committee of the World Federation of Neurosurgical Societies. He is going to be the chairperson of the next session. Lucas, thank you for coming.
Thank you, Nasser. Thank you for these kind words. I'm joining the congratulations of Professor Miguel Araez, and I enjoy really much in this educational symposium, especially because it is devoted to the pediatric neurosurgery. And in order not to waste time, my sincere congratulations to Professor Satoshi Kuroda and to Professor El-Ghandour for their great initiative and the consistency in organizing this educational event. So far, we heard excellent presentation and excellent discussion with great interest for within the participants. Now, it's my pleasure to invite Professor Satoshi Kuroda to give his lecture about pediatric moya-moya disease.
Thank you very much, Professor Rasulik, for introducing me. Can you see my slide?
Yes.
Okay.
Yes.
Today, I would like to talk on bypass surgery for pediatric moya-moya disease. This is a photograph of a city of Toyama, my home city. This is a Toyama railway station, and this building, that's my apartment. I'm living on the top floor of this building. So every day I can enjoy a very beautiful view of Japan Alps. At first, I would like to talk about the concept and diagnosis of moya-moya disease. I published this review article about moya-moya disease in 2008 in Lancet Neurology. And this definition of moya-moya disease is progressive stenosis of the terminal portion of the internal carotid artery and its main branch, including ACA and MCA. And to compensate the cerebral ischemia, many perforating arteries start to dilate, and it looks like moya-moya. It's a it means puff of smoke. So Professor Suzuki from Sendai named it as moya moya vessels. So this disease is called moya moya disease. This is a very typical findings of cerebral angiography. You can. This is a 6-year-old boy's angiography. Now you can see a very severe stenosis in the supracrinoid carotid artery and the M1 portion, and also A1 portion on both sides. And the ventricular striatal artery and the choroidal arteries starts to dilate and extend to the cortical area like that. It's very, very abnormal appearance. This is a pathology of a stenotic carotid fork. Very, very thick intima and also atrophy of medial layer, and also a waving of elastic membrane. So lumen of the carotid fork is very, very narrow. This is very typical time course of moya moya disease from stage 1 to stage 6. On stage 3, moya moya disease is most remarkable in moya moya disease. And extra carotid artery system start to supply collateral blood flow to the brain. This is one example. This is a middle meningeal artery anterior branch supply the blood flow to the ACA area like that through the falx anterior falcian artery, and also a posterior branch of the middle meningeal artery is supplying collateral blood flow to the occipital lobe like that. And this is a population of moya moya patients. As you know, both children and adults suffers moya moya disease. And most of children develops transient ischemic attack or ischemic stroke. But in adults, moya moya disease, intracerebral hemorrhage can occur, as well as TIA, ischemic stroke. And the incidence of moya moya disease is very high in East Asia, including Japan, Korea, and China. And the familial occurrence of moya moya disease around 20%. So nowadays, mutation of some genes is identified. This 3 years girl developed a severe headache, and at initial examination, right carotid artery was moderately stenotic, and there was no abnormality on MRI. But 1 year later, the disease stage markedly developed, and she suffered marked cortical atrophy in temporal lobe and also parietal lobe, because the disease stage of the PCA also advanced within only 1 year. So we have to avoid such sad story for small kids. So we have to perform bypass surgery to rescue them. As you know, we can perform both indirect and direct bypass for Moya kids. The advantage of indirect bypass is a very simple and easy procedure. But indirect bypass requires several months to create surgical collaterals. So the incidence of perioperative ischemic stroke is much higher than indirect direct bypass. On the other hand, direct bypass can quickly improve the cerebral blood flow just after surgery. So incidence of perioperative ischemic stroke is very low, and TIA and headache attacks quickly disappears after surgery. But we really need intense training to perform a direct bypass for Moya kids. And also, it should be reminded that direct bypass may induce post-operative hyperperfusion. It's quite important to reduce complication. Anyway, first concept of our surgery is we prefer both indirect and direct bypass. It is called as combined bypass. And this is a history of development of indirect bypass for these 60 years. The donor tissue for indirect bypass include temporal muscle, dura mater, and STA, and Garrier tissue, omentum, and also pericranium, P. So about 20 years ago, I established a new indirect bypass surgery. It called as EDMAPS because I use dura mater, temporal muscle, STA, and the pericranium for indirect bypass combined with STA, MCA anastomosis. And you should know that the extent of craniotomy completely determine the extent of development of collateral circulation through indirect bypass. If you make a small craniotomy, you can get small collaterals. But if you make a much bigger craniotomy, we can get a very wide collateral circulation onto the brain. And in pediatric Moya disease, this issue is very important because if you make a craniotomy on the temporal area, frontal lobe is exposed to severe ischemia even after surgery. But if we make a craniotomy extending into the frontal area, we can get good cerebral blood of circulation, including frontal lobe. It's quite important to improve higher brain function of Moya kids, I believe. So second concept of my surgery is wider is better. This is a procedure of STA and EDOMAPS. This case is 8-year-old girl, and she had very low blood flow in the bilateral frontal area. It looks like a very old guy. We check the cause of the STA and trace the skin incision like this and make a drape and dissect the STA under the surgical microscope like this. This is the main trunk of the STA, and this is the parietal branch of the STA, and this is a frontal branch of the STA. And this is a frontal pericranium for indirect bypass. And this is a temporal muscle, of course. And usually I make a craniotomy like that because I would like to preserve the middle meningeal artery, because the middle meningeal artery is a very important collateral source for the ACA. And we preserve the middle meningeal artery like that. And this is a main branch of the middle meningeal artery, and we open the dura like this. And this is a photograph of STA-MCA bypass. I will show you with the video later. And after STA-MCA double bypass, we insert the dural pedicle into the epiarachnoid space for indirect bypass, and then put the frontal pericranium on the frontal lobe like this. And finally, we put the temporal muscle on the brain for indirect bypass like this. This is a video for a 4-year-old boy. This is a line of skin incision and dissect the STA. This boy had only one branch of the STA. So I made a single STA-MCA anastomosis. I am dissecting the STA from the scalp flap. And I always repair the galleal tissue after the dissection of the STA to avoid delayed wound repair. And this is pericranium. And this is temporal fascia. And I always use surgical microscope from skin incision to skin closure, even during a craniotomy like this. In this case, middle meningeal artery was completely free from a sphenoid wing, so procedure was very easy. And open the arachnoid and identify the recipient. This is a frontal branch. And I opened the Sylvian fissure to drain the cerebral fluid, spinal fluid continuously like this. It makes very easy to perform bypass surgery in a very dry field. Now I'm preparing STA, and the end of STA should be make like fish mouth to enlarge the orifice of bypass. And I use the 11-0 nylon thread for small kids because recipient artery is very fragile in a small kid. And finally, I check IC green like this. And finally, I perform EDMAPS indirect bypass. And this is the preoperative internal carotid artery angiogram showing markedly developed moya-moya vessels. But this is the post-operative external carotid angiogram showing both indirect and direct bypass working very well. So after surgery, moya-moya vessel markedly regress. This is the preoperative and the post-operative CBF map. Good recovery of blood flow. And this is M&M after STMCA and EDMAPS. There was no mortality, but there was 2.4% of 30-day morbidities, including ICH. ICH probably occurred due to hyperperfusion, and also ischemic stroke occurred in 7 hemispheres. This is a long-term outcome after STA, FCA, and EDMAPS. Totally 93 cases were followed up for 5 to 20 years. Mean follow-up period was around 10.5 years, including 35 kids and 58 adults. And I always follow MRI and MRI angiography every 6 or 12 months. During follow-up, only one adult patient developed rebleeding about 10 years after surgery. So risk of recurrent stroke was calculated as 0.1% per patient per year. I summarized these long-term clinical results in the paper published in Journal of Surgery very recently. So please read this paper later. And this is an education symposium. So I would like to briefly talk about the training of bypass surgery for medical students and residents. He is my resident, and I recommended him to use chicken wing because the artery, ulnar artery and brachial artery of chicken wings is very, very useful for bypass surgery training like that. And he made 10,000 stitches using chicken wing. So now he can perform standard STA MCA bypass very safely and very quickly. So you should follow him by using chicken wing bypass training. And in this March, I published a textbook about moya disease from Springer Nature company. And this book has many knowledge about moya disease. So I would like to recommend this book to all of you. So finally, STA-MCA anastomosis and EDOMAPS is feasible and very effective procedures for pediatric and of course also adult moya disease. This procedure would be one of the best choice to prevent further cerebrovascular events for longer than 10 years, probably by widely providing surgical collaterals to both the MCA and ACA territories. Thank you very much for your attention.
Thank you, Professor Kuroda, for sharing your outstanding experience and knowledge about moya disease with us. We have a few questions, but I suppose it is estimated to go with the lectures and then to have a discussion at the end of the session. So I would like to invite Professor Kazuaki Shimoi from Japan to give his lecture about surgical treatment of craniosynostosis. Although I am now supposed to speak, I will invite Professor Kazuaki Shimoi to speak if he is ready, in courtesy of this order, cranial to peripheral nerve.
Okay. Do you have my slides?
Yes.
Okay. Okay, thank you very much, everybody. I'm really happy to be a part of this lecture. Today, my talk will be about surgical treatment of craniosynostosis. and I do not have any COIs to disclose. So today I would like to talk about, everyone knows that craniosynostosis surgery is invasive. So everybody wants to have a minimally invasive surgery method. But I would like to ask you that should it be okay to be minimally invasive? So craniosynostosis is a condition in which 2 or more of the skull bones are fused prematurely. And also they have a form of syndromic synostosis, which is multiple skull bones and or bone outside of the cranium are affected. This is a crouson, this is apert, and also you can see a cloverleaf skull correlated with Pfeiffer disease. So craniosynostosis can result in cosmetic deformity as a potential limitations in brain growth and development. And the neurocognitive impact of this condition is just starting to be studied more thoroughly. And the indication of the surgery will be the correction of the aesthetic issues and prevent possible future developmental delay. So craniosynostosis is a very small world. I did a quick PubMed search. If I typed craniosynostosis, only 6,200 papers came out. And on the other hand, in the highlight of neurosurgery, cerebral aneurysm had 32,000 papers. The frequency of craniosynostosis is told that 1 in 2,500 live birth. In Japan, actually, it's been a rare disease, and now the registration program is prepared from Professor Kai. And in African countries, please let me know after this talk. In Japan, scaphocephaly is the most common. And when you look worldwide, metopic synostosis seems to be increasing. And if we focus in the African countries, we know that in Northern African countries, oxycephaly is the most common. There's a paper came out from the 70s. They say that the most common variety, oxycephaly, represents in Egypt. Also after, in the paper came out in the 80s, it is also oxycephaly is the highest even compared to scaphocephaly. And if you look at Algeria, the oxycephaly is the 80% of all craniosynostosis in their series. So I had a chance to write a chapter in the textbook of pediatric neurosurgery. I cited the review of Renier, who had the highest number of these oxycephaly patients. 1/3 came from North Africa, and the age of diagnosis was 6 years old. They presented with multisutral synostosis with diffused digital markings in craniograms. And 1/3 had IQ below 80, and papilledema was found in 70%. Increased ICP was found in 2/3. So I will go back to the surgery. This is a 7-month-old scaphocephaly. You can see the big skin incision, and we literally rip his scalp from most of the skull, and we put it into pieces and then put it back together. And this is a CT scan. You can see our plastic surgeon loves to do this barrel stave osteotomy, and they crack the bone, and you can see that to have a wider space. But still, this surgical indication is for aesthetic issues. In older kids, we do a distraction osteogenesis. We put a distractor here. And because of this frontal bossing, we put another distractor to shorten it about 10 millimeters. But this procedure needs 2 surgeries, and there is a long hospitalization. So this is one of our surgery. You see the skin incision is in the posterior area. And literally, we are ripping almost all the skin from his skull. And the plastic surgeon will do the designing. And after that, the neurosurgeons will remove the bone. And we will put the distractors Now you can see the green stick fracture, what they love to do to widen the skull. And after all, we put the distractors here and put the distractors here to shorten the frontal bossing. And we put back the scalp, and this is the end. So still, this is invasive. So in trigonocephaly, you see this keel-shaped forehead, and the indication is to obtain the normalization of anterior skull factor. And you see various procedures. And what we do is cut the superior lateral side of the orbit, put small barrel staves in the orbital bar, and leave the medial side intact, and move the orbital bar anteriorly and make a green stick fracture like this in the CT scan. So also we cut the temporal bone with the temporal muscle attached and fix it to the orbital bar with the absorbable plate to avoid temporal or hollowing. So you can see that after this procedure, we have an extended orbital bar with blood supply, and the pre-op and post-op images look like this. And the plagiocephaly, this is a typical case of plagiocephaly. You see a harlequin sign here on the right side, and still also this plagiocephaly has effect on the skull base. Professor Duroko has published a classification. If the skull base is slanted, you need further correction after the first surgery. So this is the image after surgery. You can see that we have touched here the anterior skull base to release the affected orbit. The outcome looks better. And now you know that craniosynostosis is invasive. It's like ripping C3PO into pieces and put it back together. So we can understand that we would like to have a minimally invasive surgery, compare those to those invasive surgery. So what we do is use a posterior cranial vault distraction osteogenesis method. This was actually invented by Dr. Elizelov in the orthopedic area. And plastic surgeons have put this osteogenesis in craniofacial surgery. And what we do is cut the occipital area, put the distractors, and also if they have Chiari malformations, we sometimes add FMD at the same time. So this is the image after the distracting. And if we need more intracranial volume, we put the distractors on the frontal area. And if we only need to remodel the frontal area aesthetically, we do frontal orbital remodeling. So our concept is, if we need intracranial volume, we do the posterior side first and leave the anterior side for aesthetic issues. So this is one case that we did the posterior distraction and added the frontal advancement. We gained 16% and 8% after the first and the second surgery. This is the one that we just done remodeling here, so we don't gain a lot in the second surgery. So after the first surgery, you see all the gained percentage of the intracranial volume, and after the advancement, you see higher volume obtained. If it's only for remodeling, the percentage remains like around 100%. Also, the volumetric measurement of the recent cases, you see the volume is getting to normal. And this is another case of Sedgwick-Shotton syndrome. You can see the deformation of the forehead and the brachycephalic shape. So we did the posterior advancement first, and we did a 30 millimeter distract. You can see the widened skull, and we did the remodeling of the forehead. And now he has a better shape. and the MRI looks like the corpus callosum is widened to see as normal. So the advantage of cranial distraction is the bone transplant is not necessary. The blood supplies remain from the dura, and there's no extradural dead space. And if we do 1 millimeter per day, we can obtain simultaneously scalp expansion and also adjustment of the skull. We can adjust the shape of the skull after surgery. The drawbacks is the long hospitalization. We need 2 surgeries to remove the distractors. And the only vector for the expansion is limited. And it is difficult to adjust the shape when the skull's deformity has a cord. And also they can feel a gap in the expansion site. So the blood loss is lower when we use distractors. To prevent blood loss, we often use cell savers, and we obtain around 100 plus 78 cc's of blood, which could obtain from the cell saver. There are a lot of papers coming out like autologous blood banking or erythropoietin or intraoperative cell salvage, but now the promising agent right now is tranexamic acid. And the other group in Japan, they use this multi-directional distraction osteogenesis. They make a cutting of the skull and put the anchor in each bone. And they put an anchor at the temporal base, and then they can pull these anchors in the way that they want to. And just recently, our colleague, one of our Japanese colleagues, Dr. Kameda, had put up a nice video in neurosurgical focus video, so please refer these. And I'm not really sure, but when I chaired the poster session in ISPN, maybe I have shown this MCDO method, which was done from Africa. So if someone knows, please let me know. And now this is the famous endoscopic surgery followed by cranial remodeling helmet, which was started by the Texas group. It is surprisingly, but they can have the facial slant coming back remodeled. And the outcome looks very good. They see the correction of the anterior fossa. And Professor Proctor from Boston has presented his excellent results from 500 consecutive infants with craniosynostosis, which was underwent this surgery, and they found that it is really less invasive. But they pointed out that the head circumference normalized, but they didn't talk about the development. So maybe it is because they include everything, like including syndromic and non-syndromic, or maybe very early surgery was effective in non-syndromic cases. But still, the Paris group had pointed out that even in scaphocephaly, sometimes not, the indication of surgery is sometimes not only to correct the cosmetic problem. So I'm looking forward to see the data from them about the development. And there are springs, and also the springs results looks better. In summary, posterior cranial vault distraction is a reasonable expansion for gaining intracranial volume. It is not necessary to obtain an excessive frontal orbital advancement, but they have limited expansion direction, long hospitalization, and second surgery. Multi-MCDO method is you can pull the skull to a desirable direction. Endoscopic with helmet and springs, it's minimally invasive. So my question is, should it be okay to be minimally invasive? So when you look at the skull base of trigoncephaly and plagiocephaly, you see the affected skull base. When you look at the paper, which was published far before, they say the coronal suture in association with frontosphenoidal and sphenoethmoidal sutures make up the largest cranial suture complex. And in the 70s, they say that it is recommended to go downwards and inwards to include the heavily overgrown sphenoid ridge. So my question is, can endoscopic surgeries in springs can do this for going to the skull base? So can endoscope in springs can expand the volume of the frontal lobe and correct the deformity of the anterior fossa? So the take-home message is, everyone knows that craniosynostosis surgery is invasive. Even the main consideration of surgery is aesthetic. So everyone is looking for less invasive surgery, but they still have pros and cons. There might be some cases to consider more about the development and the increased ICP. And it is not an issue that plastic surgeon may need to consider, that we should be more aware of this issue. Thank you very much for your attention.
Thank you, Professor Shimoi, for this excellent presentation. Very, I would say, stimulating for discussion. Now I would propose to answer the questions which are related to the first two topics, starting from questions for to Professor Kuroda. Is bypass a definitive treatment for moya moya? If not, would be any alternative and definitive treatment? You have all these questions also in a question Q&A chat, so you can see that I believe Professor Kuroda. So this is the question for you, and you have another question that if there is age indication for direct bypass. You see the question, I believe,
Yeah.
Yes. Okay. So you can answer now, please.
Yeah. Direct bypass is available for any pediatric patient with moya moya disease. So I always perform a direct bypass as well as an indirect bypass. Even if the patient is 1 year old or 2 year old, same. It is feasible, possible.
Okay, great. Thank you. And we have another question for Professor Shimoi. Opinion about the stripping of unilateral suture in coronal plagiocephaly with asymmetric orbital limb. Will it correct itself after the stripping, or it should undergo skull base reconstruction as well? You have this question in a chat box.
Yes, I can see the question. But the data coming out from the Boston group and the Texas group says that they are fine. It's very surprising for me, but still I would like to remove the sphenoid ridge and go all the way to the anterior fossa, because if I cannot believe that only removing the fused suture will be the complete treatment for this, because this was abandoned. But the interesting thing that Professor Proctor was saying, that he said that they were releasing the fused suture. So we'd like to see the long-term outcome.
Thank you. And Professor Tito Perilla would like to give a comment on both lectures.
Thank you, Dr. Lucas. I would like to make some comments about the talks of all symposium. First of all, I would like to congratulate to Dr. El-Ghandour, because with his protocol, I believe we will do better surgery in this type of surgery that is not so fancy, like made one malformation, one tumor, one aneurysm, but is very important because this pathology is very often all over the world. And he put in my opinion, his finger in the point. We have to take care and don't forget any little situation about the management of skin, operator room, and technical issue, because many people think doing one BP tune is easy, is nothing, is one surgery that they don't have to have most care. And he chose in very nice paper and protocol how he can decrease the infection in his environment. My congratulations. And this is very nice example for all over the world, all neurosurgeries, that we have to take care about this surgery. Second, it's very interesting how we are trying to bring all techniques 100 years ago by Dandy, but now with all requirements, we will try to see how we can learn more about the physiopathology of the CSF production and how is all situation with the hydrocephalus. This is very nice point, must point. And also, I have to tell some personal issues. 30 years ago, when I performed a lot of vascular surgeons, I agree that the best at only treatment for moya disease is directly bypass, because we are changing the physiopathology of that entity. My congratulations. And also, I am very surprised that how the neurosurgeons all over the world, even in craniosynostosis, is trying to develop minimal invasive surgery for made very nice work and have less risk, especially in the blood loss for the patients. My congratulations. And also for you, Lucas, and Dr. Arraez, and all moderators, and especially to Dr. Nasser, for combine the real world in one efficient and nice symposium that give to us many new technologies and many new solutions, special for help the patient. Thank you, Nasser, and all of you. Thank you.
Thank you, Tito, for these valuable comments. Since we are now running out of time, I believe 15 minutes of extension will be acceptable, since
yes, of course. I would like to thank Professor Tito Perella, and I think, Lucas, we can extend the webinar for 15 more minutes, or if you would like to evaluate, because you have still didn't say your talk. Do you like to take more questions now, or to proceed to your
I would like to proceed with my presentation, and then if some questions can be answered also by typing, so we can solve the question during the in order not to waste time. I mean, regarding me, we can take another questions now, but I believe to finish the presentation and then to
open discussion. Okay,
yes.
I agree with you. And so let me introduce you. It's my pleasure to introduce my friend, Professor Lucas Rasolik. He is the last speaker in this educational symposium. Professor Lucas Rasolik is president of the Serbian Society of Neurosurgery, and he is chairman of the Peripheral Nerve Surgery Committee of the World Federation of Neurosurgical Societies. He's going to speak about peripheral nerve surgery in pediatric population.
Thank you, Nasser. Once again, congratulations for the outstanding organization and excellent presentation for all presenters, all panelists, and nice questions. Greetings, regards from Belgrade, from Serbia. I'm a peripheral nerve surgeon, neurosurgeon, as you all know. So we explore all the topics related to peripheral to pediatric neurosurgery, and this is also from cranial to peripheral, very important field of neurosurgery, also in pediatric population. So I don't have any disclosures. as you can see in the literature, you can find a lot of papers, not so many, but some papers which very consistently and valuably enroll all the pathology related to the pediatric neurosurgery, which is in direct correlation to the neurosurgery. And you can see all aspects of peripheral neurosurgery, including trauma, tumors, and entrapment syndrome. So is the pediatric peripheral neurosurgeons practice or not? You will see the answer in this, let's say, overview of all types of pathology, all types of procedures, and all types of surgical activities in treatment of the small patients, and finally, outcomes. So, as in adults, we can say in general that in pediatric population, peripheral nerve pathology is the same, but this is another environment, small people, and the biological characteristics highly influence the outcome of this patient. So, trauma, generally speaking, trauma is one of the main reason of the lesions of the peripheral nerve in children, and nerve lesions may account for 10 to 15% of total cases in special units. Usually they are associated with vascular or tendon lacerations. Basic consideration regarding classification of nerve injury given by Seddon and Sutherland are the same in pediatric population, as well as the pathophysiological changes of injured nerve. But biological potential for regeneration and other aspects such as brain plasticity is of utmost importance and much more stronger in pediatric population. So in just to remind how we can experience different type of injuries within the cross-sectional schematic drawing of the peripheral nerve, you can see that we can face with all degrees from 1st to 6th degrees of Seddon and Sutherland classification, which is highly directed us in which type of procedure will be performed in children. The regeneration after neural injury is very famous valor degeneration and regeneration. So it is also in the pediatric population. And generally speaking, three basic types of peripheral nerve injuries are frequent in children: stretch-related lacerations and compressions. Etiology is different in different age groups. Since we consider pediatric population from 0 to 18 years, and usually there is a transition period from 18 to 17, 16, 17, 18 to 19, 20 years. And this is something which is commonly related to the, let's say, both peripheral and adult neurosurgery. So in the neonatal period, most frequent injuries are obstetric brachial plexus injuries. From 2 months to 3 years, glass and knife lacerations are most common causes of injuries. From 3 to 8 years are fractures and sport injuries, and from 9 to 5 years, maybe all different causes of injuries. What is very important characteristics of pediatric in pediatric population regarding peripheral nerve injuries? Majority of these cases are usually within first 3 degrees of Sutherland classification, so spontaneous recovery can be expected in these 3 degrees in almost 95 to 98% of patients. If there is another degree like 4th, 5th, and 6th degree, there surgery will be needed. And this is usually progressive proximal to distal anatomic motor recovery, which is very important. So in the management of these diseases, important is clinical assessment. Clinical examination is of outstanding importance, and you can very easily evaluate each muscle, which is innervated by each individual nerve. You can use diagnostic procedures, additional like EM, electrophysiological evaluation and imaging techniques, MRI, high resolution ultrasound, and angiography. And functional recovery and prognostic factors in these cases are dependent to the biological advantages. So functional recovery is better if the patients are younger, and very rarely cold intolerance or chronic pain are developing. Timing of surgery is essential, like in the adult population, but as sooner we operate the patient, the outcome will be the better. Indications are clear. Open and closed injuries. There is an open injuries treatment algorithm with open injuries and missile injuries, which is practically similar like in adult population. As well, algorithm for treatment of patients with closed injuries in pediatric population, which is consistent of monthly evaluation. So surgical procedures are surgical release or decompression, then neurolysis, nerve repair, and different type of tumor resections in a tumor pathology. Nerve repair techniques are direct repair and the nerve transfers. So you have to use all these techniques depending on the intraoperative findings. In the brachial plexus lesions, priority functions are forearm flexion, shoulder stabilization, abduction of the external rotation and the shoulder, sensory function of the thumb and index finger and hand function, although it is, let's say, open for discussion. And then direct repair is the best possible option. Direct repair techniques are neurolysis, split repair, and direct nerve suture, and direct repair with the graft. Neurolysis is a standard procedure, which can be external or internal. End-to-end suture is ideal procedure for early reparation. Direct repair with the graft is usually performing when the nerve tissue defect is longer than 2 centimeters with different types of procedures such as cable grafting, interfascicular grafting, fascicular grafting, or vascularized grafting. Then cable graft or modified cable graft is using in large nerve polyfascicular trunks. Interfascicular grafting is in interfascicular nerve, and it has its advantages and disadvantages. Post-operative procedure is usually within 1 year, a gradually increase in range of movement and intensive physical therapy following with electrostimulation. And factors influencing outcome are age, type of the nerve, type of the injury, associated injuries, surgical treatment within timing and microsurgical technique, and post-operative rehabilitation. So these are imperfections of nerve grafting and the nerve transfer, which is used in each individual situation. Nerve transfer procedures are practically the same as in adult patients. Just to show a few words about obstetrical brachial plexus palsy, which is, let's say, most common and important traumatic lesion of the brachial plexus in the neonatal period. 1 to 1,000 deliveries with risk factors, and usually it's traction of the newborn with the head abducted from the shoulder dystocia, with clinical presentation which can be upper brachial plexus, extended upper brachial plexus, C5, C6, C7, or total brachial plexus palsy. And strategy for reconstruction of this, depending on how much roots are available and preserved. This is the Allen-Gilbert scale for evaluation of motor function in children with brachial plexus injuries. So management is in the first 10 years after birth is usually immobilization with shoulder adducted and elbow flexion, and then intensive physical treatment and evaluation. And if there are no signs of recovery of 2 months, child should be examined by a neurosurgeon. So this is a case of spontaneous recovery of the beginning of the spontaneous recovery in obstetrical brachial plexus palsy. Indications are if there are no recovery after 3 to 9 months, some surgeons are favoring early surgery around 3 months, but it is let's say usual to wait 6 to 9 months following birth, and surgical treatment is depending on how much roots are available and the source of the reinnervating axons are available. So this is in terms of prognosis, spontaneous recovery may be expected in 70 to 80%, and this is a very important question to restoration of the hand. So in this is some cases we can see some general characteristics of the children, trauma in children, in very young children below 4 years of age, and between 4 to 12 years of age and 12 years of age and above, with some case study such as 15 years old female, traumatic brachial plexus palsy, chronic upper brachial plexus lesion with EMG, post-traumatic pseudomeningocecal C6, C7 foramen on the left, and indications of treatment in these cases with algorithm of treatment of this patient. This is closed brachial plexus injuries, and nerve injuries associated with brachial plexus are axillary nerve and musculocutaneous nerve. And one case of obstetrical brachial plexus palsy, 7 months old, complete brachial plexus palsy with viable C6 and C7 roots, harvesting the sural nerve and preparing harvesting the sural nerve from both legs and preparing the and complete supra and infraclavicular exploration of the brachial plexus with preparing the roots for transplantation. So we performed intraplexal nerve transfer C6 to the anterior division of upper trunk, C6 to the posterior division of the upper trunk, and C7 to the inferior trunk, and spinal accessory nerve branch to the suprascapular nerve via anterior approach. This is a surgery 3 months ago, and so far early for any kind of evaluation. And I will stop now here due to the time, because there are a lot of characteristics of individual nerve injuries depending on upper limb lesions or entrapment syndromes or tumors, depending on each individual type of pathology and each individual nerve. Just to show one case, 15 months old male with median nerve injury cut with a broken glass, lesion of the median nerve, direct nerve repair was possible, exploration of the median nerve, and this is surgery. The section of the neuroma and the suture of the nerve. And this is a complete anastomosis, direct suture without tension of the suture line, and nice recovery after that. Then complete recovery, and that's it so far, because there are a lot of many other possibilities to talk about different types of nerve lesions on the upper and lower limb requiring surgery in different type of pathology. I will just overview them now, including some rare situation like neuropathies associated with limb lengthening procedures and burn associated neuropathies. Entrapment syndromes in children are rare, but also can be present, and in best treatment option usually appear to be a surgery. And these are different type of compression lesions through the upper and lower extremity, including some of them which are very rare. just to remind you that this is a population from 0 to 18 years. It's not only, we are not talking about only newborn babies for entrapment syndromes now. And different type of, let's say, rare entrapments, such as hereditary neuropathies with liability to pressure pulses, and tumors, benign and malignant tumor, which are very easy to make a diagnosis, but surgery is in some situation can be very controversial. This is in terms of either biopsy or not, or preservation of the function of the nerve, and resection of the nerve in cases such as malignant peripheral nerve sheath tumors with reconstruction of the nerve function, and a lot of tumor pathology. Is some good results in majority of cases, depending on the procedures, neurolysis and suture nerve grafting, around 80 to 90% good recovery, good results up to the direct nerve repair. This is according to the individual nerves and timing of the surgical treatment, and results of nerve repair regarding length of nerve defect, and serious comparison. And regarding nerve transfers, so the best results can be expected in the reparation of the open brachial plexus injury in the C5 and C6 nerve roots, upper trunk, lateral, posterior cords, proximal end of the brachial plexus nerve branches, and good recovery is to be expected in 90% of neurolysis and 87% of nerve grafting. So neurosurgeons should do pediatric neurosurgery because we know how to handle nervous tissue. We were born with microscope in our hands, and we perfectly know how to perform a neurological physical examination. So in conclusion, nerves recover faster and better in children. Penetrating injuries should be treated surgically when nerve lesion is diagnosed. Obstetrical brachial plexus should be treated after 3 months without signs of recovery. Entrapment syndromes are extremely rare. Think about some underlying genetic conditions, storage disease or syndromes. Peripheral nerve tumors account about 14% of tumors in children. Complete resection of benign lesions with nerve repair if needed. In malignancies, nerve reparation is not advised, and the outcome of nerve repair and nerve transfers are better than in adults, and pediatric peripheral nerve system surgery is definitely neurosurgical practice. So keep calm and raise awareness about and love brachial plexus surgery. And this is our event. We were very eager to have you, to host all of you last year in Belgrade, since it is the biggest continental neurosurgical event, European Congress of Neurosurgery. Unfortunately, due to the COVID-19 pandemic, it was not possible to organize this event last year. But we hope sincerely that we postpone the Congress for October 2022. And we really do hope that everything will be possible to meet in person in October 2022. So I cordially would like to invite you all of here and to see all of you in Belgrade, in Serbia. Thank you very much for your attention.
Thank you, Professor Lucas Rasolik, for this very important talk. Actually, I learned from your talk much, and hopefully we have to address this important subspecialty, which I know that most neurosurgeons need to be well trained in doing peripheral nerve surgery. I can see, Lucas, I don't know if you follow the chat panel, but I have a question for you. Sir, what is the total success rate of nerve anastomosis if the patient come after 5 to 6 hours of injury?
100%.
Okay, that's very clear-cut answer.
Clear cut.
Okay.
5-6 hours after the injury, direct nerve suture, 100% recovery.
And I have another question on the chat panel to Professor Shimuji. I don't know if you can help me, Lucas, because you are the.
Yeah, I'm just looking also.
Yes, yes, but I have seen a question for Professor Shamushi about craniostenosis. It is in the chat panel.
Yeah, I think I already answered.
You have the question?
Yeah,
you
yeah.
answered already? Okay.
Yes.
Lucas, do you have any other questions or comments?
I just want to say that this is a field of neurosurgery which has a nice and not so easy learning curve, but can be very useful for neurosurgery practice in Africa.
Yes, this is one of the important subspecialties, and I hope that we can address this important topic or this important subspecialty either as presentations or either as courses or workshops in the near future.
Nasser, you know where people from Serbia are traveling now? Only in,
Yes.
only in Egypt.
Yes.
You cannot travel anywhere, just in Egypt. So this we can easily organize some kind of activities, even with El-Ghandour. You know El-Ghandour, this is my friend and our colleague, also in committee for peritoneal neurosurgery. So this is very easy.
Yes, actually, Lucas, you are doing a great job in the peripheral nerve surgery. And I think now we have to close the webinar. I know it's late in Japan now. It's 12:25 after midnight. And I apologize about this delay that we extended the webinar for 25 more minutes. And would you please, Satoshi, accept my apology? Actually, the discussion, the discussion was very interesting and it was great. Satoshi, before I close the webinar, would you like to say something?
Yeah, thank you very much. I could really learn a lot of things and also really enjoyed today's webinar. So I'd like to thank Nasser and other speakers and also all of audiences. I hope all of us can advance the neurosurgery over the world. And after the cessation of COVID-19 pandemic, I would like to gather all together and talk tomorrow's neurosurgery. Thank you very much.
Thank you, Satoshi. Actually, it's a pleasure to work with you. And thank you, Lucas, very much for your continuous contribution and support. Thanks to Miguel Reyes, thanks to Nelsie Zenon, thanks to all our distinguished speakers. Really, it was a highly successful webinar. And I hope that all attendees got some new information and got much benefit from our discussion and from the great talks of our distinguished speakers. Thanks to all of you for contributing to this neurosurgical activity. And I would like to announce that next Friday, webinar number 36 is going to be about skull-base surgery. We have 4 eminent neurosurgeons, James Evans from United States of America, Basant Mishra from India, Ali Al-Mashani is President-elect of the Pan-Arab Society of Neurosurgery, and Walter Jean from Neurosurgery. May I not forget to thank my organizing team, Mr. Ahmed Magdi and Dr. Hassan Ala and Dr. Ahmed Adil. He is lecturer of Neurosurgery at Cairo University. I would like to thank all of you. Thanks to participants, and hope to see you soon again in another occasion in the near future. Thank you very much. Thank you.
Thank you very much.
Thank you, Satoshi.
Thank you. Thank you.
Thank you very much. Thank you. Thank you, Lucas.
Thank you, Nasser.
Thank you for all.